Thank you, Hemant, for the kind invitation, and it was a very nice talk by Dr. Muralidhar about all the diabetic manipulations that we are now doing with the small gauge surgery. What I'm going to talk about is giant retinal tears, where the management has come from something very complex and has now actually been made quite simple if you approach it in the right way, and the results are much better now as compared to what used to be in the long time in the past. It used to be a dreaded condition, but now it's just one of the conditions that we manage on the retina. I've had some travel supports and honorariums over the year from these companies. The giant retinal tear per se is any tear which is greater than 90 degrees, and that's what is defined as a giant tear. Even a smaller tear than 90 degrees could be have the same problems or issues as a giant tear, but theoretically this is what we consider a giant tear. And it usually occurs at the posterior edge of the vitreous base and has to be differentiated from a dialysis, which is different, which is actually a splitting which is happening right at the edge of the vitreous base, where the retina is tearing apart from the ora serrata, and both have different sets of prognostic aspects. What has changed the management of these systems is basically the viewing systems, the wide field systems, which nowadays we use either a biome or a contact-based system, RV, VO, Ocular. A lot of companies make a similar wide-angle systems by which we can see the periphery of the retina very well, and that's why the management has changed. And the other is perfluorocarbon heavy liquids, and for both of these we have to thank Dr. Stanley Chang for introducing both of these to our armamentarium. So classically, how a giant tear is dealt with is approaching it nowadays with a small gauge surgery. You can do a good job. If there's a lot of PVR, you might want to put a buckle, and you might resort to a 20 gauge as well. But otherwise, you could use a small gauge approach in most situations. So the first job is to make sure that you remove all the vitreous, which is the core vitreous, and then approach and make sure that the base is cleaned up, the attachments of the vitreous are well removed, so that the tear is mobile and free from all its attachments. So you can see here that this is one of the edges. Most of these giant tears would have weak areas around and in other parts of the retina, which would have initially led to the formation of the tear itself. So once you have a freely mobile tear, you would put in perfluorocarbons, which would help you make sure that the tear goes back, flattens out. You can also assess if there is any traction in some area which needs to be cleared. And once you put in perfluorocarbon, you can actually go and also clean up some of the base and the periphery. And then of course do a good laser. And after that, you could either do a direct PFCL oil exchange, and I like to first go on to air and do a good exchange with air to the PFCL, remove it, and then put oil at the end. So this is how typically a case of a giant tear would be managed in this situation. Of course, you could end up with tears which are giant tears but have, after a certain time of their presence, they would lead to a lot of PVR changes, because once a tear occurs, there's so much pigment dispersal that the PVR factors are enhanced in these situations. So a tear like this is more difficult to manage because the retina is not supported on all sides by its attachments. You have a huge area which is unsupported, and so dissection is difficult. Even perfluorocarbon liquid has to be used sparingly, because you can only fill up the eye up to the area of the traction. Beyond that, it would tend to go behind. So you have to carefully make sure that the perfluorocarbon is applied rightly. Now here we assess there is traction, so we have endodiathermized and relieved some of this traction in this area so that the retina flattens out, and at the end you have something like this. So here the approach would require more manipulation as compared to what I showed you. And at times there would be a 360 tear which is freely mobile and with absolutely no attachments and have PVR changes. Now here you probably need bimanuality of some sort to realign it, because there's no way you can support it at any given point, because all the attachments are not there. So here the bimanuality would help the situation, and it would help you put it back in its right perspective. At times it can occur with a colobomatous situation. Colobomas itself are a problem to manage at times, and now you have a giant tear along in a coloboma. Pretty much the same scenario as a normal tear. You would approach it the same way, except that you need to assess all the edges. You need to assess the margins of the coloboma with the normal retina, the junctions, which are very crucial, because that's where a lot of these the collection of the fluid takes place from. Although a case like this, where a giant tear is formed, it probably has a peripheral weakness apart from the colobomatous zone, which is causing that. So here, once again, you free the flap of all the attachments, and then use perfluorocarbon, which is the best tool to assess how the tear is behaving, and then do a good laser. Of course, you would need to spare some of the laser area where the macula is, because these cases at times, depending on how much the coloboma is impinging on the macular area, you might further reduce vision if you laser the macular area. So you need to be careful. You do laser the margins, but spare the macula in those situations. This is right after the attachment. You can see that we've done a mild laser here, not much as compared to a more aggressive laser to the peripheral areas. These are examples of some of the pre and the post tear attached. At times, because you use so much perfluorocarbon and you have so much bare area of choroid, we do once in a find subretinal PFCL globules or floating globules of PFCL. Usually would not cause any problem if it's isolated or it's freely mobile. If it's next to the fovea or amphovia, you might have to go in and do something about it in that situation. Rarely what you can also encounter is slippage, because these tears, again, this happens because of traction happening at both the edges, and at times patient might come back with a slippage and you need to reoperate these cases and iron it out, the whole edge of the slippage. Now this is an example of a tear which is very posterior. You can see that we've actually buckled it because it has PVR changes. There is a buckle in the periphery. In such cases, we do like to buckle in some form, because the inferior part is not very well tamponaded at times with these. Although the buckle effect should be light, because if you put a very heavy buckle, then it tends to evert the tear and undoes the damage. It kind of overdoes the damage which is already done by the tear itself. But with this kind of PVR changes, you're already expecting problems in some situations. So here you see that somewhere a subretinal PFCL has slipped through one of these areas, which you go in and of course clean it up. At this area, you go under the retina and absorb it. You can see how posterior this tear edge exists and is not very peripheral. So once again, we clean up everything and slowly retract and get as much of the margins as possible, because there's already very little retina temporal to the macula, and you already have PVR changes happening 360. So carefully we relieve the traction to a large extent and put the retina back with perfluorocarbon. At this juncture, it did not require a retinectomy at this stage. We further flattened it as much as possible. But you can see how much pigment is already involved in this area because of the traction which came up with this posterior tear, and iron it out. And later on did an aggressive laser because it's posterior, of course, much away from the macula, and flattened it and put it back. The tear was well settled for about a month, and then the patient came back at the second month with retraction. This is the same case. You can see that the tear edges have retracted. So no matter what you do, such cases are very likely to come back at times because they already have a lot of PVR in it. So here you can actually see all these laser marks on the bare choroid which we've done. The edges which are already posterior have further retracted. The inferior PVR is still merging. So we remove the oil, go back in again, try and put back whatever retina we could. Also did an inferior retinectomy because now the inferior part is not possible to settle back on its own accord. So once you have the retinectomy in place, you can again refill with perfluorocarbon up to the edges and do a good laser and resettle the tear. And after that it's attached at this juncture. But this was just an example of what I'm showing, that even if you probably put it back altogether does not mean, in cases which already have PVR, these are the classic cases which are prone to redetach, and one needs to keep a watch on these patients. Sometimes you can have a nucleus drop which is complicated with a giant retinal tear, because maybe the surgeon has tried to fish the nucleus or put in a vectis much beyond the pupillary zone where one should not approach. So this is an example of a nucleus line with a big tear which has formed typically because of manipulation. And here the aim is again to clean up the vitreous first and then put a lot of perfluorocarbon so that the nucleus has to be taken out. Since the retina is mobile, you need perfluorocarbon so that it keeps the retina away while you phaco-fragment the nucleus. You can see that the tear edge is reaching very posterior. It's a tear extending from right up from the superior arcade going right to the periphery in this area. So here once again we put perfluorocarbon. We are fragmenting the nucleus at this stage. Once that is done, then you need to put back the tear. So now you see the whole extent of the tear. It's coming from this area and slowly going towards the upper part. And it's a ragged, ill-formed giant tear which is there. Again, a classic case which can lead to PVR. Here again we put a buckle. We've flattened it well, done a lot of laser, and then put back the tear. This is the pre and the post 1 month pictures of the same patient. So endo laser is important. I think you need to do a good aggressive laser to most of these cases, especially inferior part, because that's where the PVR starts off from in these situations. If on the follow-up, in your outpatient follow-ups, you feel that there is some retraction of the flap, you could actually augment laser and try and contain it if it's not approaching posteriorly beyond the laser margins. Your surgery does not end with the first surgery, because most of these patients require oil. You need to remove the oil. This is a classic case of an oil removal being done in a patient of a giant tear at about maybe 6 to 8 months or whenever. And after removing oil, we usually do an air fluid exchange and then assess the area of the tear carefully. You can see a good laser marks all around, well flat retina, and the aim is to assess that the retina is, the tear edges are well adherent, and that's when you can be assured that you have a good chance of no redetachment. But we all know that oil removal does lead to a small risk of redetachments in these cases. These are again residual PFCL bubbles, which again, as I said, sometimes you see it on the retinal surface, sometimes you see subretinal, sometimes you see it mobile. They might be lying in the NTH segment. But again, you can remove it when you do the oil removal in most situations, because they are mobile and they never sit on one place and cause any damage usually. Lastly, the other eye of these patients has to be looked at carefully and prophylaxis done to all the lesions which you suspect. This is a case of a lattice, a long lattice which is going almost 360 degrees in different segmented areas. So this is, we should always remember checking the other eye of these patients. In the past, people used to even advise buckling in these cases, but of course, I don't think today we would like to do something so invasive. A prophylaxis and to tell the patient to come in early if he has any symptoms is probably the best idea in terms of management in these situations. Thank you very much.